Yes. Assalamu alaikum warahmatullahi wabarakatuh. Hayyakum Allah. Welcome everyone. It gives me a great deal of pleasure to kickstart the webinar today under the umbrella of the Saudi Health Council and the National Heart Center. The webinar is themed across hypertrophic cardiomyopathy, a new era of precision and care. It gives me an absolute honor and pleasure presenting Dr. Ali Shahrani. Dr. Ali Shahrani is a senior consultant cardiologist who's currently heading the cardiac imaging in King Fahd Cardiac Center at King Saud University Medical City. He's had extensive expertise in imaging and cardiology and cardiomyopathy, and he's going to be giving us all three talks. And we're going to start off with the first talk of navigating the complex diagnosis and variable presentations of hypertrophic cardiomyopathy. For the attendees, I'd like to just request for for everyone to post up your questions as we go along in the Q&A box. I'll try to consolidate them and prepare them. We're going to have a Q&A session in the last 10 minutes of the webinar. Dr. Ali, my pleasure, and the floor is all yours.
Thank you, Dr. Mariam, and I'd like to extend my appreciation and gratitude to the Saudi Health Council and the Saudi Heart Association for organizing these continuous education activity, particularly in cardiomyopathy and hypertrophic cardiomyopathy. I'd like also to thank the sponsors and the organizers for their support to get this activity or serial webinars to be produced and presented this year. Before I just go, I wanted to share. To go back a little bit in history and see what happened to this hypertrophic cardiomyopathy when first diagnosed before the era of the echocardiography. And it was described the first time in 1957, between 1957 to 67, after identifying the hypertrophied muscle on surgery or on open heart surgery, and also seen the SAM on the angiogram. But the echocardiogram introduced the first descriptive or the hallmark description of LVH of hypertrophic cardiomyopathy as asymmetric in 1972. And then with time, the diagnostic process has evolved until we are in the era of the cardiac MRI, and now with the cardiac MRI strain and tissue characterization. So as a result of that limitation in diagnostic modalities, as well as evolving in technology, the definition of hypertrophic cardiomyopathy or obstructive hypertrophic cardiomyopathy has changed over time. First described muscular hypertrophy and obstruction, familial association, autosomal dominant disease, non-obstructive form was described in 63, and then the structural changes start to be really described and correlated with the anatomical or phenotype as well as the genotype. But what we are actually going to talk about, or what is the core of our topics these days, is the hypertrophic cardiomyopathy that results from the genetic mutation of cardiomyocyte and lead to the asymmetric cardiac hypertrophy unexplained otherwise. And this is mainly the sarcomere mutation or alteration that is resulting in hypertrophic cardiomyopathy. And that specifies this diagnosis among other diagnoses of hypertrophic cardiomyopathy that could either result from acquired or inherited causes, as we will see. It's not uncommon, it's not common. However, it's really increasingly recognized and diagnosed, as I mentioned, as a result of that increase in the diagnostic ability of different modalities. The main genetic mutations have been described in 8 genes, and that leads to this myocardial disarrays as a result of the genetic mutation. And that's the hallmark pathologic changes that contribute to the hypertrophic cardiomyopathy. The Clinical presentation of patients with hypertrophic cardiomyopathy, as you all know, and it's very important to just remind people that it is not always symptomatic. And in fact, most of the cases could really be either part of a family screening, if we are lucky and get a family screening, or an incidental finding. Minority of patients will come with a very significant clinical presentations or related to either heart failure, limitation in functional capacity, chest pain, or arrhythmia. The physical findings, although I have seen a lot of hypertrophic cardiomyopathy, it's very tough to really hear that medium pitch systolic ejection murmur that can be heard at the left liver sternum border. The ECG findings, they are non-specific. However, the most important thing is the ST wave changes. Patients with hypertrophic cardiomyopathy are usually classified in one of the four profiles, either benign stable disease, which is patients who really have asymmetric LVH, but they don't really have symptoms or very minimal symptoms. But then we have the four major clinical profiles that we are considering them where we really need to pay attention to their diagnosis as well as management. One is sudden death, which is not going to be part of our talk today as it has been covered in the arrhythmia related to hypertrophic cardiomyopathy. There is the progressive heart failure as a result of obstruction or advanced heart failure in end stage with non-obstructive, which they can be interchangeably one profile. And then we have the profile where they have atrial fibrillation, stroke, etc. The phenotype characterization is very important, and we learn more about the phenotype as the imaging diagnostic modality is getting better. But the sigmoidal HCM, which is the most common one, is where we have a basal asymmetric or asymmetric LVH, where basal septal is mainly involved. Then there's the reverse curvature hypertrophic cardiomyopathy, which we see it. Although I don't really have data about it, but it's observed to be more among certain Black African patients, and it could really be difficult to differentiate from hypertensive heart disease. And this is around 80% of myoenvironment genetic positivity. Then there is this apical hypertrophic, which is very well when it's recognized, it's easy to really see. However, due to the technical variation in echo, it's not seen in most of the patient as it's seen in the MRI. And finally, the neutral hypertrophic cardiomyopathy, where you see that thickened septum all compared to the basal septum only in the sigmoidal. It's not only about hypertrophied muscle, but also there is what's resulting from that is obstruction either in the LVOT or about 10% of the mid-ventricular obstruction. The changes that happen as a result of that Venturi effect that happen with that dynamic obstruction by pulling the mitral valve apparatus, including the SAM or systolic continuous motion of the mitral valve and the chordal SAM, the changes in the papillary muscle anatomy, as well as the mitral regurgitation resulting from SAM. As a result of that, the left atrial dilates. Hypertrophic cardiomyopathy or asymmetric thickening of myocardium could really involve the right. Also, very rare, and we don't really have a lot of data about it, but also RVH could also be involved. And finally, it's the fibrosis and altered myocardial tissue. Now, why do we need to really go ahead with multimodality imaging right off the bat when we see the patient? Because we need to really have an optimal and correct diagnosis because the first line diagnostic modality echo is highly variable as a result of the technical and the nature of the test. And also the different phenotypes or phenocopies of LVH, their acquired or inherited causes, as well as we need to characterize the myocardium because it's not only about mechanical, but also about the tissue characterization, and finally for risk stratification. The first modality for diagnostic or diagnosing and hypertrophic cardiomyopathy is echo. And it's simple. If there is any thickening of the septum or LVH more than 15 millimeter, the criteria included 13 to 14 millimeter may be considered if family history of a positive genetic mutation is there. Although we have seen people who have progressed from 13 to 15 to 16 over a year or two rapidly. So keep eye open when that septum is actually in the range of 12 to 13, even unless there is an explanation, particularly in young patient. The hallmark of that diagnosis is also the cavity is not dilated, and that is very important to differentiate from athletes, as well as absence of any disease that could cause LVH, particularly fixed mechanical obstruction like severe IS, etc.
Dr. Ali, can you just put it on full screen? Because some people are saying pictures are probably not as clear.
Sorry.
Thank you. That's
So,
perfect. Yes.
okay, so again, so the echo assessment of LVOT obstruction, this is a dynamic obstruction as a result of that proximal septal thickening, a narrow LVOT, abnormal mitral valve, as I mentioned, abnormality of papillary muscle. The gradient is where we have to really pay attention to. Resting gradient more than 30 millimeters is a diagnostic for LVOT obstruction, and that's at resting patients could be 30 to 35% patient. When they have that resting gradient, they are symptomatic. Some patients they have that latent, which is provoked or can be elicited by either exercise or Valsalva. About 40% of patients, they have a non-obstructive hypertrophic cardiomyopathy, and they usually follow a more benign course. So quickly, because I think there was a fully talk about the diagnostic imaging, the echo assessment is very important, particularly when you are able to define the LV wall thickness through the septal thickness, as well as the LVOT gradient, and differentiating that wave, which is dagger shape, compared to the other coexisting or mimickers of LVOT obstruction. So in the M mode, you can see the systolic anterior motion of mitral valve kissing that septum, as well as the mid-systolic closure of the aortic valve compared to the normal where you don't have it as clearly in the mid-systole. One of the most important things that you have to look at is the late peaking of that wave as a result of the LVOT obstruction, which indicates a dynamic nature of that obstruction compared to any other obstruction seen with subaortic valve membrane or with aortic valve itself or aortic stenosis, as well as the variability with some of the maneuvers, including Valsalva and amyl nitrate. So what to do when you actually have a suspicion of an LVOT obstruction and the gradient is not clearly? There is this Valsalva maneuver. There is the squat to stand where you decrease the venous return and worsen the LVOT obstruction, and the amyl nitrate, which is I don't think it's widely available, which will also decrease the venous return and increase the heart rate. And then there is, which is I urge everyone who actually are able to do it to do an exercise echocardiography to assess the LVOT obstruction more accurately compared to the just resting gradient. This is a very famous approach that has been published by the American Society of Echo. And if the patient has an hypertrophic cardiomyopathy, and there are symptoms that could have been attributed to the LVOT obstruction, and the gradient at rest or with provocation, such as with Valsalva or squat to stand, is still less than 50 millimeter per mercury, or on the resting echo, then the recommendation is to go ahead with exercise echocardiography and then assess for the LVOT gradient as a result of SAM or chordal SAM. If it is still 50 millimeter or more, then that is a definition of obstructive hypertrophic cardiomyopathy, and then we go through the cascade of the candidate or eligibility for intervention. Again, these are the tracing where the LVOT velocity can be actually differentiated from as a dagger shape and late peaking compared to the aortic valve velocity that's dooming. And if there is also coexisting superimposed LVOT and aortic valve velocity, you could actually differentiate it in many patients. One of the also tricks is also differentiation of that LVOT outflow tract obstruction compared to the mitral regurgitation, where you see it also as a dome shape versus the dagger shape. So um, there is also an echo. There is the mid-ventricular obstruction and aneurysm, which represent around 3% of patients in HCM registry. And it is not related to SAM. And this is commonly among patients who have that reverse curvature. And you see it also with patients with hypertensive heart disease. And that is one of the most trickiest parts, whether this is really related to hypertrophic cardiomyopathy versus others. Now, you could really utilize multiple imaging modalities, including MR, to assist for fibrosis, because with hypertensive heart disease, we're very unlikely to have that patchy fibrosis versus also looking for strain and echo. Now, it has been observed that the gradient in the mid-ventricular cavity could reach up to 30 millimeter mercury, and that intracavitary velocity peaking mid compared to the late that you will see with the LVOT. Then what happens is abruptly it ceased, and then you will have another wave coming early diastole as a result of that emptying blood from the apex down to the LVOT. So it is very tricky when you really assess the mid-ventricular obstruction compared to the LVOT obstruction. So what do we mean by the diagnosis challenging? It's clear. I mean, we're going to look at the alveolar wall thickness, and then we will look if there's SAM and gradient, and that's hypertrophic cardiomyopathy. Well, diagnosing a patient with hypertrophic cardiomyopathy is one of the, I think, most tricky and challenging. I would say up to 50%. There are lots of questions about the diagnosis, and it takes more than imaging modalities, more than clinical encounter, and probably not diagnosed until we see the patient after multiple encounters and visits. And that is related to two things. The two hallmarks of that is the asymmetric LVH and the LVOT obstruction or a gradient. Now, the LVH is how can we diagnose the hypertrophic cardiomyopathy or differentiate it compared to hypertensive heart disease? I mean, it's easy to say asymmetric versus symmetric, but first line modality is echo, and there is lots of patients who are missed actually on echo as a result of thinking that it's symmetric. Presence of other diseases, especially in the mid-age and the 50s, ATTR amyloid, other inherited cardiomyopathies that could give you the phenocopies of the LVH, such as glycogen storage disease, Anderson-Fabry disease, Friedreich's ataxia, Danon-Pompe's disease, and others. So the other source of challenge is the LVOT gradient mimickers, hyperdynamic LV, mitral regurgitation, the concomitant aortic stenosis, subaortic valve, ridge, all of these could actually contribute to an acceleration of flow in the LVOT without a really easy diagnosis of an LVOT obstruction. So this is one of the challenging cases, which was seen actually recently 2 weeks ago. She's a 58-year-old female, and she's known for hypertension on valsartan 160 milligram BO daily. And with this dose, she has been followed up by cardiology for more than 4 years and has been with the follow-up with worsening symptoms wise. So she was labeled to have HFpEF, likely hypertensive heart disease at age of 58. Although when we look at her blood pressure readings, they are in the range of 120 to 140 on 160 milligram BO daily. And she had serial echocardiograms over the last few years, and we reviewed the description of the echoes, and they describe briefly as a mild to moderate concentric LVH with normal LV ejection fraction. Over time, with the worsening of the symptoms, she has been prescribed furosemide for 40 milligram BO daily. Then it was increased to BID. And then she was added, aldactone was added to her medications to alleviate these symptoms, but she has never improved. At the end, she was sent to have an MRI, did not improve, so she was actually sent to have an MRI to rule out amyloidosis. But this is actually her MRI. So when we look at her MRI, she actually can, it's easily, you see, there is asymmetric LVH, mainly involving the septum inferior septum, while the anterior and the lateral wall are with the normal for thickness. And if you look at the 4 to the 5 chamber, there is a very clear flow acceleration at the proximal LVOT, which is questionable that there is probably SAM or chordal SAM. So my encounter with the patient came after the report of the MRI was issued. So she came to me and she said, "Well, I have been for years being treated, and you're actually bringing me with a new disease." Well, I said, "This is your disease, so we have to repeat your echo." We repeated the echo, and this is her most recent echo, clearly showing an LV septum that is around 1.8. And there is actually, if we slow the movement, there is some. If we see here, that is Sam. So and there are two things that whatever your experience is as a cardiologist or echocardiographer, please slow the loop and go back and take it one loop by loop. Sam and Matt. The two ankles, you have to really look for them and go slow loop by loop to see them because you easily can miss them. And that's what happened with this patient. And the patient, this is a 5-chamber view showing clearly that there is an LVOT obstruction. Not only that, but if we look, this is her gradient about 59 resting. And that is explaining a lot of the symptoms that she has and the poor response to diuretics. So we decided for quality assurance to go back and look at her previous echo and what could have been done wrong. And this is one of her, I just want to take one thing. The last echo that before we did our echo shows that clearly there is actually an LVOT obstruction. But what? There was no interrogation of that. So we don't know what was that gradient at that point. So what could have gone wrong with this patient diagnosis? Well, the first, there was no accurate measurements of the wall thickness. One of the wall thickness measurement that we saw was around 13 millimeter, which is normal considered, but it did not include the whole thickness, thinking that's probably part of the RV or trabeculae. But if you suspect that, and you're not sure whether this is 13 or more than 13, MRI is there, where can help you to really see that. The symmetry in the previous echoes, because she was described to have moderate concentric LVH, is an issue. Why? Because an echo, we know that a lot of trabeculae can be seen as a part of the concentric LV wall, while it's not really. On MRI, you can see it as a trabeculae, and you can really define the real thickness of the wall or of the LV. They're easily missing SAM or chordal SAM or overlooking them because of the quick reporting or review. There was probably no proper interrogation of the LVOT or mid-ventricular gradient. She was not sent for CMR earlier. And finally, if you see a hypertroph, think hypertroph. This is a hypertrophied, this is a thickened wall. Let's really make sure it's thickened, it's not hypertrophic, and we can get an advanced imaging through the MRI. So the role of MRI is simply, it confirmed the diagnosis. And all guidelines, both American and European, has put that for the first time diagnosis as class 1 recommendation. It gives you a proper LV wall thickness and assessment. It is better resolution and measurements in several segments, and it's able to identify the maximum thickness more accurately compared to the echocardiography. Thickness location can be defined well. You see on the left, clearly this is a reverse curvature or probably neutral, while actually on the right, you can see that this is apical clearly. Delayed gadolinium enhancement is very important. It correlates well with the fibrosis that is more commonly to be encountered in hypertrophic cardiomyopathy as a result of that myocardial disarrays versus other forms like hypertensive heart disease, which is basically a hypertrophied myocardium and the risk stratification and prognosis. There is some other technique that we can use, parametric techniques like native T1 mapping, which can help to differentiate hypertrophic cardiomyopathy from hypertensive heart disease, as well as from athlete's heart, Fabry's, and cardiac amyloid. So that is all actually emphasize the importance of the cardiac MRI in the early diagnosis of hypertrophic cardiomyopathy and guiding the therapy. So the take home here is echocardiogram is the first line diagnostic modality for hypertrophic cardiomyopathy. However, there is a careful attention need to be focused or directed to the LV wall thickness and symmetry, the structural changes such as aneurysm, the LVOT hemodynamics, mitral valve structure and function, and then CMR is actually a must for any patient who is either diagnosed with hypertrophic cardiomyopathy on echo or suspected to have that. And it has to be done because one, to confirm the diagnosis, two, it actually gives you more insight about the accurate measurement of the wall thickness, as well as the asymmetric of the LV wall and tissue characterization and differentiate phenocopies of the hypertrophic cardiomyopathy, such as the mimickers, hypertensive heart disease, Fabry's, etc. Thank you.
Thank you very much for a phenomenal talk. Maybe I've written here three things that I've learned with this talk is, always slow the loop down in a hypertrophy to make sure you're not missing out SAM, have a low threshold to CMR, and I liked how you said see hypertroph and think hypertrophy. So thank you very much for that. And now our second talk is actually looking at why HCM all of a sudden became super interesting is because we've started to have emerging targeted therapies and redefined procedural interventions. And these things have not happened for at least a couple of decades. We've been stuck with the same stuff over and over again since, our basic residency times. So the floor is all yours. Thank you, Dr. Ali.
Thank you. Yeah, so I agree with you. This is very important. We're very happy that there is a targeted therapy. There are things that can be done for these patients to alleviate their symptoms, and probably, hopefully, with time, we will have survival outcomes too. So, without any further delay, we know that the patients with hypertrophic cardiomyopathy are treated with beta blockers. And if they are not tolerating the beta blockers, we'll go with the calcium channel blocker, non-dihydropyridine, disopyramide, Cayman. But the really game changer nowadays is the cardiac myosin inhibitors. And it has been around for a while, but the invasive therapies. What is happening now is I think we're getting better at the invasive therapies because we're getting actually centers for hypertrophic cardiomyopathy. So I'll just start by, I know most of you guys know these things, but it's really good always to have it for many reasons. One, even if we all love what we are actually experiencing nowadays with cardiac myosin ATPase inhibitors, still beta blocker is required to be the first line therapy, both insurance, government payer, everyone. And nowadays, we really have to think about how much do we need to spend and what do we really need. So it is really a responsible practice and value-based. So beta blockers is still the first line therapy. And I think that everyone should really be on beta blocker. Myself, we put everyone on beta blocker. Some people advocate only for symptomatic patient. Definitely any patient with obstructive hypertrophic cardiomyopathy, but also non-obstructive who are symptomatic, they may benefit from that. And the reason is beta blocker, they work through the several mechanistic work. They are chronotropic, they are inotropic action, so they really suppress and give the myocardium a time to fill as well as to really contract appropriately. The calcium channel blocker, verapamil, is the only calcium channel blocker that have been tested and effectively seen to really manage the symptoms in patients who are intolerant or cannot get beta blockers. Disopyramide, so when I talk about beta blockers and calcium channel blockers, all the data available now over time for the last 40 years are observational, small studies, but it has been observed well, and it's really making sense. And beta blocker is probably the only player that have never been tested, but it has been passing all the exams. So Diazoparamide has been tested actually. It's a class 1A antiarrhythmic drug. I've seen it once. It is really good. And there is some data that suggests has a very important impact on improving the exercise tolerance and functional capacity and has low pre-rhythmic activities. However, it is limited by anticholinergic side effects and the access to it is very limited. What really changed the game nowadays and become we start to really interested in, although I have been interested in this for a while because of the imaging and sudden death, but the myosin ATPase inhibitor, which is the first in the class, and it acts as a cardiac myosin ATPase inhibitor. Simply, it reduces the actin and myosin not to really marry and cross-bridge formation, which makes sense because it really reorganized the myocardium. So these myocytes can really, instead of the disarrays, it's just released from each other a little bit, which gives, it's explaining why the effect is actually seen. And I'd expect that this could be reproducible in other diseases. So now what happened is this has been tested in 2 randomized controlled trials. I'll go quickly over a couple of them. Oh, well, they are the only two, Explore and Valor. So what happened is they enrolled around 250 patients. They gave them simply in Explore a mavacamten at a titrated dose based on their metabolism, starting from 2.5 to 15 milligram for about 30 weeks. And looking, they included patients who are really sick, which means they have NYHA class 2 to 3 symptoms, and they have a gradient of 50 or more. So this group, by the way, is a small group in our cohort, at least in our cohort at the university where we have just above 100 patients. This is a very small group. So what they were looking for is a primary composite functional endpoint, and this is important. What they looked at a peak VO2 either is 1.5 ml per kg per minute, and there is an improvement in their NYHA, meaning if they are 2, they will become 1. If they are 3, they will become 1. Or they actually have a good VO2, but they did not change in NYHA. They didn't really worsen. So that is the primary endpoint. This is very smart to measure. It's very specific and to the point. And it is really related to the practice because this is the first time to test this medicine. So we're not looking at mortality. We're looking at what could really be benefiting the patient directly. I'm not here to show the baseline characteristics, but one point that you have to see, which is the genetic testing performed in around patients who around 73. Now, if you look at the patients who did actually have a genetic, likely pathogenic or pathogenic mutational variant, is only 30% among these patients. So what happened here is the treatment difference. There is a more patient or proportion of patient achieving that composite outcome, which is either I have a VO2 of 1.5 and I improve in NYHA class by one class, or I have a 3 milliliter per kg per minute in patients after 30 weeks. Very significant between the placebo and the medication. So this is an explaining, so the composite one or two, so one, this or this, as a primary outcome. But they had several secondary endpoints. And one of the most important endpoint was measuring the LVOT gradient post-exercise. So it really dropped significantly with mavacamten. And the drop was from either 28 to 43 grade on the LVOT post exercise, which really is explained by the direct ATPase action of the medication. They have also measured that by the BVO2 and also by the New York Heart Class Association, which is improved. And secondary endpoint also by quality of life, which is also showed a better patient-reported outcome. And this is very important too. And we started to really collect patient-reported outcomes, several diseases, not only HCM. So the effect on primary outcome or endpoint across all the groups favor mavacamten. And again, very interested in HCM genetic result. And the reason is a lot of patients around, they don't have access to the genetic workup. So mavacamten is still better if patients have a pathogenic or likely pathogenic significantly, but also if the variant of unknown significance, still mavacamten is better. If the patient is negative, overall, it shows that the mavacamten is probably better, but it's if we look at the confidence interval, it's actually wide and non-significant. So probably negative. There is probably hint, but it's not really confirmed. However, the more effect is in the variant of unknown significance and pathogenic versus likely pathogenic. Now, they went again and they repeated the study in the patients who have the same hypertrophic cardiomyopathy, LVOT obstruction, and they gave them a mavacamten. And they want to look at something. They said, okay, if you are candidate for septal reduction therapy, we're going to treat you with mavacamten, and then we'll come back and look at you at 16 weeks and see, are you still a candidate or not? So what happened is, at 16 weeks, what they looked at, if you take mavacamten, guideline eligible for septal reduction therapy is very low compared to the placebo, significantly, which means that it actually eliminated the need for any invasive therapy at 16 weeks. That's really big. So after 16 weeks, 18% of patients on mavacamten met the guideline criteria for SRT to choose or undergo SRT versus 77% of patients with placebo. The post-exercise LVOT gradient significantly lower at 16 weeks. Also, the LVOT gradient, either resting or Valsalva, is lower with 16 weeks. This is really short. If we look at the other biomarkers, for example, propane B, both Explore and Valor has actually shown a drop, which means that not only LVOT obstruction that has been relieved, but also the myocardial mechanics has it's relaxing. It's taking time to really contract. It's less strain with time. And the safety point was actually to check the ejection fraction periodically. So Explore and Valor, when we look at it, there was no change in ejection fraction over time. Okay, so that's the new drug. That's what we are talking about, and that's what we are all excited about, and we're trying to utilize it as appropriately in our patients. Luckily, this year it was registered by the Saudi FDA, and it's available and accessible. Now, there is a strict criteria, institutional based, for who actually should be included and given the treatment. I encourage people to start your patient right off that when diagnosis on beta blocker, titrate to the most, and then judge the need for that based on the inclusion criteria for these medications. Now, there is still the septal reduction therapy, which is invasive therapy. We kind of, unfortunately, overall, I think it's limited. It's not as we expect nationally, but we hope that it's going to be available and accessible. And we would love to see it focused as expertise in one of the centers. And it's either surgical myomectomy versus alcohol septal ablation. And, it achieves success rate of more than 80% of cases. It lowers the gradient, reduces SAM and MR, improves symptoms and functional. However, its the best candidates are usually less than 50 years old, people who have left atrial size less than 46, and absence of atrial fibrillation in male patients. Complications are very limited, but has been observed. AV nodal block, left bundle branch block is very common, and ventricular septal defect and aortic regurgitation. This really needs an experienced center to achieve such outcome. This is in the best hands globally. Alcohol septal ablation. This is a selective injection of alcohol into the septum, septal perforator artery to create a localized scar, done under the guidance of a contrast echo, and similar outcomes as surgical overall, lower gradient and improved symptoms and functional capacity. However, AV block is the main complication, and septal perforator's anatomical variation is a challenge to technical such procedure. There is a recent meta-analysis in 2020 that looked at both and looked at the surgical myomectomy versus alcohol septal ablation. And as you may see that maybe there is no difference actually in all-cause mortality. There is no cause in either short or long. There's no difference in sudden death or stroke, but the peri-procedural complication probably more favoring the alcohol septal ablation versus the reintervention and need for pacing, etc., that will actually be favored by the surgical myomectomy. So the French nationwide database analysis have shown that there is a more use of alcohol septal ablation. And I think it's actually an expertise, the learning curve. More interventionists are actually learning more of alcohol septal ablation, and there is more access to it compared to the others. The decision should really be based on patient eligibility, multidisciplinary heart team, and the center expertise. There is other management consideration, which is management of atrial fibrillation. I kept it out of the scope of the talk for the day, but it's actually multiple areas that we should probably talk about it in the future. So in general, beta blocker titrated to the maximum tolerated dose is the first line therapy. Non-dihydropyridine is the alternative to patients who are intolerant to beta blockers or continue to be symptomatic. Cardiac myosin ATPase inhibitor mavacamten is effective in improving the symptoms, functional capacity. It lowers the LVOT gradient even as early as 16 weeks and overall quality with no significant impact on the LV ejection fraction. It is recommended to be started as a second-line therapy for time being. I expect with time, with more data that we have, even post-market surveillance, we will have it probably an earlier intervention. And the surgical septal therapy is probably going to be less performed, these procedures, as we see more success and more outcome confirmed by the cardiac myosin ATPase inhibitors. Thank you.
Thank you so much again, Dr. Ali. And again, maybe the take-home messages here are beta blockers, beta blockers, beta blockers, then verapamil, then disopyramide and mavacamten, and then the septal reduction therapies. And that is really, although the difference between them is minimal, it goes back to the expertise of the center and the volume that they're doing and the success factors that they have. And whatever they're comfortable with, usually is what's best for the patients here. So moving along to the last topic, and then we're going to have the Q&A session. The next topic is actually tough and extremely important because it's what puts everything together. It's really highlighting the importance and the criticality of having a multidisciplinary care team. And more importantly, the concept of proactive family screening, which always brings up a lot of controversies, let's say, and a lot of difficult discussions. So the floor is all yours.
Okay, so thank you. Yeah, so why is hypertrophic cardiomyopathy is unique? It's really unique if you look at it as well among us as a cardiologist. It's not as, first of all, there is a diagnostic challenge, and it's the clinical identification, imaging techniques, and expertise. And with that complex diagnosis, nowadays there are therapies. So it's really, زي ما يقولوا الحرج زاد علينا. We have to really diagnose people well. because there is therapy. In the past, oh, you know what, maybe we don't really need, there's nothing to be done. But nowadays, there are actually therapies which are very effective. So we really need to diagnose people well and take our time because there are therapies. And the other thing is, it's an inherited disease, which means it goes beyond the patient that you see. There is family, there's kids, there is activity that the kids will engage in. So there's a lot of issues related to the inherited part of it and the family involvement. And finally, it doesn't come alone. It is always associated with several comorbidities, including sudden death risk, it's atrial fibrillation, ischemia, etc. So HCM is unique. And I go into an argument, and other people would say, well, such as other cardiomyopathy. And believe me now, other cardiomyopathies would, I think they are very important to diagnose and taking care, but there is no therapy. There is no therapy like what we are living nowadays with hypertrophic cardiomyopathy. So it is very important to really take your time in diagnosis. And so what does that mean when you look at this? The diagnostic challenge, the therapy, the comorbidities, the inheritance, the involvement of family, that all makes us in front of a very complex disease that needs a multidisciplinary care. But if we look at the predictors of prognosis that has been published, it has been really repeatedly say it's age of symptom onset, the genotypic status, the family history of sudden death, and whether there is a excessive wall thickness, if there is obstruction fibrosis. And this is a classic, what we have been taught about risk for sudden death. This is simple. This is actually simple. But that is not really what plays a role in the prognosis. It's early access to care by a capable team. How? So this is a study that was published in 2020, and this is one of my favorite studies too. They looked at the large database well, I think it's actually in New Haven. So what they looked at, they found that what is the difference in the outcome if patients with hypertrophic cardiomyopathy managed by general cardiology, whether they are in a high socioeconomic status or low socioeconomic status, general cardiology in general, the patient with low socioeconomic status are likely to have a less survival if it's by only general cardiology. But if it's a specialized care through a specialist clinic and specialist that is really aware and expertise in the disease, there was no difference in the survival based on high economic status or low socioeconomic status. They actually stratified patients by socioeconomic status because it's one of the most important determinant of access to care in the United States. And unfortunately, it's probably in some areas because either educationally they don't really know that they need to go to the doctors or they don't need to be followed up and have that. But then they take them by high socioeconomic status and low socioeconomic status. And in both that, when you are taking care by a specialist or a specialized care, your likely survival is higher than if you are by general cardiology. So this is very important about the care. What about genetic testing and family screening? Half of the cases are inherited as a Mendelian genetic trait. The sporadic cases are either they did not have an incomplete penetrance of a variant inherited, or the de novo variant that were not carried by the parents, or autosomal inheritance, recessive inheritance. So why do we need to have the genetic testing? One, it's confirming the diagnosis. It is an important preclinical diagnosis. It is determining also your cascade genetic testing in the family and guiding the reproductive decisions. So, I mean, for women and whether they really want to pursue pregnancy, etc. And this should not really be done by a cardiologist. The genetic counseling has to be done by a cardiac genetic counselor. I know that there is a limited number of them around, but this could be done virtually. So centers that did not really have access to that specialized care could really engage with centers that have this service and get this done. The cascade genetic testing of family members help identify those who will benefit from surveillance thereafter. And it's nowadays we have the gene panels, and we're very lucky at the university to have the National Center for Sudden Cardiac Death, because they have access to the genetic workup fast. And we get the 8 sarcomere genes, which is representing 60% of familial cases. And I think that we don't really have, I'm not aware of any local study that actually confirmed this or disregarded, but I know that there are people working on this. So inshallah, in the next couple of years, we will have more data about it. It's not only about this panel of 8 genes, but also there are few genes that actually it's good to have them done also to rule out, particularly in a younger patient, who their extracardiac are not really clear, including the PRCAG2, glycogen storage disease mutation, LAB2, Danon, and GLA Fabry's, as well as the ATTR gene mutations and genes related to rasopathies. The American College of Cardiology and AHA has really have a very good approach to decide on what to do for patients who are phenotype positive. If the patient has a phenotype positive, they could go for stress testing, etc., and they could go also for serial evaluation of clinical status, and you could identify the gene in them and see their families. If they are a phenotype negative, it's really still good to have if the family is known with a pathogenic or likely pathogenic variant, to go for assessment of that variant. So if it is not there, then screening ECG and echo is not actually at intervals of 6 months. And if the patient has the family variant, if the patient doesn't have family variant, you stop doing anything about the patient. But one important thing, and this is really done in expertise centers, because the variant, there's every 2 to 5 years, there is a re-evaluation of how clinically significant are these different variants. So far, these 8 variants that has been identified in the panel has been really associated with a sound clinical outcomes. Again, this approach is very good for patients who, when you have the HCM index case and you really want to do the targeted genetic testing. So the disease-causing variant or likely pathogenic or pathogenic versus no variant identified, you are actually going to look into your cohort, which is probably should be done by certain centers in the kingdom, to really reclassify the variant importance or clinical importance in presenting the phenotypes. So this is very important for centers which are going to pursue having an HCM clinic. There has to be an approach to doing the genetic testing and proactive family screening. So the take-home message here is it's a unique clinical condition with a complex diagnostic process, availability of therapies, and extending to family members and associated with several comorbidities. Management and follow-up by a specialized clinic or center is associated with overall better outcomes. The genetic testing is crucial for identifying the pathogenic variant for cascade genetic testing of the family and decision on the following surveillance. Pre-test genetic counseling is a key step in our culture, and it's a very important, and it's really one of the most important thing is, I guess a lot of patients, if you offer them an invasive therapy, it's probably easier than saying, I want to screen your family. It is culturally, it is still a fear-spreading discussion, and that's why we're trying to just minimize the effect of it through using a non-physician staff to engage people, social worker, as well as the genetic counselor, etc. I still think that there has to be a multidisciplinary HCM team approach, which is evolving in some of the centers, at least around the city here. Thank you.
Thank you so much, Dr. Ali, for a phenomenal series of talks. And I think, your last talk highlighted beautifully that such complex disease spectrum cannot be handled by a single specialty, and it needs a true multidisciplinary specialized team to handle the psychosocial events, the consequences of it, the genetic counseling, and screening and going forward. It is definitely a challenge, and access to such technology and such resources are rare, but I know that your center is doing fantastically well, and I can attest to that. I've referred patients there. So thank you very much for that. I've been told, and we need to kind of have a hard stop at 10. So unfortunately, we don't have time for questions, although I think I've had 4 lined up here. Maybe we can discuss them in another talk. But thank you very much for that. And thank you everyone for attending. It's phenomenal. We have تقريبا 200 attendees coming in and listening to your talk. So thank you very much, Dr. Ali. And thank you
Thank you.
very
It
much
was a pleasure.
يعطيكم العافية وفي أمان الله. مع السلامة.